Imagine undergoing like this painstaking multi-hour microscopic surgery. I mean, a surgeon meticulously reconstructs the tiny, fragile bones inside your ear using microscopic titanium struts and precisely carved bits of your own cartilage.
Right, it is incredibly delicate work.
Exactly. So the operation is a total success. You go home, a week later you feel a tickle in your nose, you sneeze, just to be polite, you pinch your nose and keep your mouth closed.
Which is a huge mistake.
A massive mistake. Because in that fraction of a second, this massive aerodynamic pressure wave shoots up into your skull, hits the underside of that delicate surgical reconstruction and completely blows it apart.
Just completely ruined.
Hours of microscopic carpentry ruined by a single sneeze. So welcome to our deep dive. Today we are taking you into the high-stakes, intensely fragile world of human ear reconstruction, disease management, and auditory mechanics.
It is a wild ride.
It really is. Our mission today is to unpack this incredibly granular set of medical and surgical protocols to understand the literal nuts and bolts of how we hear and, well, how doctors fix it when it breaks.
And it is truly a masterclass in microsurgery. I mean, the sheer mechanical nature of what happens inside the temporal bone is just staggering.
Yeah.
We are looking at an environment where surgeons operate in this tiny, dark space using high-powered microscopes. The margins for error are microscopic.
Like millimeter level.
Oh, absolutely. A millimeter in the wrong direction with a surgical drill doesn't just mean like a failed surgery. I mean, it could sever the facial nerve, causing permanent facial paralysis.
Wow.
Or it could breach the thin layer of bone separating the ear from the brain, which basically opens the door to a lethal intracranial infection.
Reading through these protocols, it reads less like biology and more like a manual for repairing like a highly pressurized, fragile clock.
That is a perfect way to put it.
But before we even get into the operating room to fix this clock, we have to understand the battlefield. I mean, how do doctors even spot a microscopic problem hidden deep inside the dense bone of the human skull?
Well, you have to map the territory first. And the diagnostic imaging used here is highly specific because of how much diverse tissue is crammed into a fraction of an inch.
Right, so what are they using?
Clinical protocols lean heavily on two main tools. We've got high-resolution computed tomography, or HRCT, and MRI.
Okay, so CT scans and MRIs.
Yeah. So if a surgeon needs to evaluate the hard architecture, like the dense temporal bone, the tiny ossicle bones, the physical walls of the middle ear, they rely on the HRCT.
Because it shows bone really clearly.
Exactly. But bone scans don't tell the whole story. If they need to look at soft tissue, they pivot to an MRI.
Right.
That allows them to see the brain tissue, the cochlear nerve, or what's known as the patent lumen of the cochlea, which is essentially the clear, fluid-filled acoustic pathway inside the inner ear.
The specific visual signs they're hunting for on these scans. I mean, it sounds like something out of a medical thriller.
Oh, the terminology is great.
Yeah. There's something referred to in the notes as the snake eye sign, seen in the superior semicircular canal.
Right, the snake eyes.
When you look at the imaging cross-section, the two openings of the canal literally look like a pair of glowing snake eyes staring back at the radiologist.
It is very distinct. And they don't just use one type of MRI either. They deploy different magnetic resonance wavelengths to hunt down highly specific destructive diseases based on, how the tissue reacts to the magnet.
Give me an example of that, because that sounds crazy.
What's fascinating here is how they track down cholesteatomas.
Okay, cholesteatomas.
Right. A cholesteatoma is a destructive expanding cyst made of trapped skin cells right in the middle ear.
Ew.
Yeah, it's not great. It acts almost like a tumor, secreting enzymes that actively dissolve and eat away at the surrounding bone.
Wait, it literally eats the bone.
It literally eats the bone. So to spot it early, radiologists use a diffusion-weighted MRI. The tightly packed cells of the cholesteatoma restrict the movement of water molecules, so it lights up like a hyperintense beacon on that specific scan.
Wow.
But on the flip side, if they use a T1 or T2-weighted MRI, they are usually looking for a cholesterol granuloma. That is a different kind of destructive cyst filled with blood breakdown products and cholesterol crystals.
Okay, so spotting this tissue early isn't just about preserving hearing, right?
Yeah.
Because if diseases like chronic otitis media, which are these severe long-term middle ear infections, if they go unchecked, the consequences escalate rapidly.
Very rapidly.
This is far beyond a standard childhood earache. The medical literature points out that the most common intracranial complication of unchecked ear disease is actually a brain abscess.
Yes.
The infection essentially creates a pressure cooker in the middle ear,
Yeah.
eats through the literal ceiling of the ear cavity, and invades the brain.
And this brings up one of the most brilliant clinical assessments in neurology. Imagine you are a physician evaluating a patient in a hospital bed.
Oh.
They have a severe ear infection, and you suspect it has crossed over into the brain cavity to form an abscess. Before you even have a chance to wheel them down to radiology, you need to know exactly what part of the brain is under attack.
Right, like where's the pressure?
Exactly. Is the abscess pushing into the temporal lobe, right above the ear, or is it pushing backward into the cerebellum?
Okay, let's unpack this because the physical bedside tests for this in the notes are incredible.
They really are.
So if the abscess is in the temporal lobe, the patient might present with nominal aphasia. They know what they want to say, but they suddenly can't find the names for everyday objects.
Right, the wiring gets crossed.
Yeah, and they might also have homonymous heminopia, meaning they lose exactly the same half of their visual field in both eyes.
But if the abscess is in the cerebellum, the symptoms change entirely.
Because the cerebellum does different stuff.
Exactly. The cerebellum handles motor control and coordination. So a patient with a cerebellar abscess will suddenly show profound clumsiness.
Right.
The doctor will perform a pass pointing test. They will hold their own finger up and ask the patient to reach out and touch it.
Sounds simple enough.
You'd think so. The patient's brain completely understands the command, but their hand will consistently overshoot or miss the target entirely because the neurological circuitry governing spatial coordination is actively being crushed by the abscess.
I have to challenge this a bit though.
Oh, go for it.
Because we just talked about diffusion-weighted MRIs and high-resolution CT scans. In modern medicine, why rely on a doctor holding up a finger? Like, why do these old-school physical detective work tests even matter when we have million-dollar imaging equipment down the hall?
That is a fair question, but the reality of a hospital environment is that technology is a bottleneck.
What do you mean?
Well, an MRI machine might be occupied, or the patient might be hemodynamically unstable, meaning their blood pressure or heart rate is crashing, and moving them is just too dangerous.
Oh, so you physically can't get them to the scanner.
Right. Recognizing these neurological deficits instantly tells the surgeon the trajectory and the speed of the infection. It tells them if they have a few hours to prep for surgery, or if they need to drill into the skull in the next 5 minutes to relieve the pressure.
Wow, so the clinical eye is basically the ultimate triage tool.
Absolutely.
Now, before surgeons even make that cut, there are a couple of incredibly bizarre environmental and biological diseases that can wreck the ear.
Oh, definitely.
One is eosinophilic otitis media. This is directly linked to patients with severe asthma. And asthma isn't just a lung issue, it's a systemic inflammatory response.
Exactly. It affects the whole body.
Right, so in these patients, a specific protein called IL-5 kicks into overdrive. IL-5 acts like a homing beacon for eosinophils, which are a type of white blood cell.
And those white blood cells flood the middle ear.
Yeah, creating this thick, highly toxic, glue-like mucus that just destroys the delicate hearing mechanics.
It is brutal. And then you have environmental triggers, like exostosis, which is famously known as surfer's ear.
I've heard of that.
Yeah. When the ear canal is repeatedly exposed to freezing cold water and wind, The body registers this as an attack on the eardrum.
So what does body do?
As a biological defense mechanism, the temporal bone actually starts growing multiple rock-hard bony swellings inside the deep ear canal to block out the cold.
That sounds awful.
It protects the eardrum, sure, but it narrows the tunnel so much that water and debris get trapped, leading to agonizing infections.
So once you've identified the brain-invading cysts or the glue-like mucus or the bony blockages, I mean, you can't just leave there. The surgeon has to go in.
They do.
But looking at the surgical protocols, there is a massive, almost philosophical architectural debate on how to clear an infection from the mastoid bone.
The mastoidectomy debate.
Right. And just so you guys know, the mastoid is the hard bone right behind your ear.
Yeah.
And internally, it's not solid.
Mhm.
It's structured like a honeycomb filled with air cells.
So when a cholesteatoma or severe infection gets into that honeycomb, you have to drill it out. And this sparks the great mastoidectomy debate, CWU versus CWD.
Canal wall up versus canal wall down.
Exactly. To visualize this, picture the ear canal as a long hallway leading to a door, the eardrum. Right behind the wall of that hallway is the mastoid honeycomb.
Okay, I'm picturing it.
Canal wall up is a conservative architectural approach. The surgeon goes in, meticulously drills out all the infected honeycomb cells, but they intentionally leave the bony dividing wall between the ear canal and the mastoid completely intact.
Okay, so it's exactly like renovating a house. Canal wall up is like discovering black mold inside the walls of your living room.
Perfect analogy.
You carefully open the drywall, you scrape out all the mold, treat the wood, but you keep all the original load-bearing walls standing. The structural integrity of the room remains identical to when you started,
And the clinical data shows this method leads to vastly better hearing outcomes because the acoustic mechanics of the ear canal aren't altered.
which makes sense.
Yeah, and it also makes it incredibly easy to fit a standard hearing aid later if needed, but there is a massive lingering threat.
Which is,
Because you left the walls up, you've created blind spots. There's a notoriously high risk of residual microscopic disease hiding in the shadowy recesses of that preserved anatomy.
oh, so the mold comes back.
Exactly. In fact, the recurrence rate is high enough that patients undergoing a canal wall-up procedure often require a mandatory second look surgery 12 to 18 months later.
Wait, really?
Yeah, the surgeon literally has to open the ear back up just to confirm that the bone-eating cyst didn't quietly return.
That sounds like a nightmare. Which is why the alternative is so aggressive.
Right, CWD.
Canal wall down. It's like gutting the room completely. You don't just clean the mold. You take a sledgehammer and knock down the entire wall between the ear canal and the mastoid honeycomb. You merge the two spaces into one giant unified cave.
It is a massive structural change.
The protocols specify that this drastic demolition is reserved for cases where patient follow-up cannot be guaranteed. Like, say, a patient traveling from a remote area who won't be back for a second look.
Or it's used in elderly or high-risk patients who cannot safely undergo multiple surgeries.
Mm.
Or if the mastoid is heavily sclerotic.
What does sclerotic mean in this context?
Sclerotic is a crucial term here. It means the bone has been subjected to so many chronic infections over a lifetime that the delicate honeycomb air cells have completely scarred over and hardened into dense, solid ivory bone.
Oh, wow, like it petrifies.
Exactly. When the mastoid is sclerotic, taking the wall down is often the safest way to ensure absolutely no disease is left behind. But when a surgeon guts the room and creates this unified cave, they have to leave it in absolutely perfect condition.
Yeah, the standard for a successful canal wall down procedure relies on creating what surgeons call a good cavity.
A good cavity, yes.
It can't just be an empty hole in the skull. It has to be impeccably smooth, self-cleaning, and well saucerized.
Saucerized means exactly what it sounds like, by the way. Carving the bone into a gentle, sloping, shallow saucer shape.
Right, because if the surgeon leaves sharp corners, ledges, or deep bony pits, dead skin and earwax will accumulate in those crevices, rot, and trigger a massive new infection.
Exactly. The floor of the ear canal and mastoid must be leveled out completely flush.
And maintaining this newly constructed cavern requires adequate ventilation and access.
So the surgeon performs a metaplasty, which involves physically cutting and widening the exterior opening of the ear canal.
And the medical guidelines provide a wonderfully analog test for this.
I love this part.
Amidst all the high-tech microscopes and millimeter-precise titanium drills, the ultimate metric to ensure the opening is wide enough for proper aeration in clinical inspection is whether it can accommodate 1 finger for a male patient and 2 fingers for a female patient.
It's a very practical reality check right in the middle of a microscopic procedure.
So let's say the demolition is finished. The cholesteatoma is gone, the mold is out, and the cavity is saucerized. The patient is cured of the disease, but because we just gutted the mechanics of the middle ear, they are functionally deaf in that ear.
Right.
This transitions us from demolition to the microcarpentry of hearing. How do we rebuild the acoustic machinery?
This involves laryngoplasty, repairing the eardrum itself, and ossiculoplasty, rebuilding the tiny chain of ossicle bones that conduct sound from the eardrum to the inner ear.
And the success rates are surprisingly robust, actually. Eardrum repairs boast a 95% success rate, and rebuilding the bone chain can reliably restore 10 to 15 decibels of hearing.
But the complexity lies in the materials. Surgeons have to choose between autologous grafts, meaning biological material harvested directly from the patient, like moving an existing ear bone, using dust from the patient's own skull bone, or taking a slice of cartilage from the outer ear.
The alternative to that is alloplastics, which are entirely synthetic grafts. We're talking about solid biomedical plastics, titanium metals, ceramics, and porous sponges.
Right.
And this is where I really don't understand the surgical preference. If we have sterile, space-age titanium prosthetics sitting in a package ready to go, why on earth would a surgeon add an extra 30 minutes to the operation to harvest a tiny piece of cartilage from the patient's own ear? It feels so medieval.
It might sound medieval, I get that,
Mhm.
but the biology of the middle ear is incredibly hostile.
Really? How so?
It is a wet, highly pressurized, constantly moving environment. Synthetic materials, no matter how advanced, carry a significant risk of extrusion.
Extrusion.
Yeah, the patient's immune system recognizes the titanium or ceramic as a foreign invader, mounts an inflammatory response, and literally pushes the prosthetic right through the eardrum and out into the ear canal.
Oh, that sounds horrifying.
It's not ideal. Autografts, the patient's own cartilage or bone, have flawless biocompatibility. The immune system recognizes it as self. It integrates seamlessly, it costs nothing, and the extrusion rate is exceptionally low.
Okay, that makes total sense then. You also see a hard line drawn in the notes against homografts, which is using ear bones from a human donor.
Yes, big red flag there.
While it saves time in the operating room, the protocols explicitly warn against the catastrophic risk of transmitting viral infections or prion diseases directly into the patient's skull. It's just not worth the risk.
Exactly. So they harvest the patient's own tissue or use highly specific synthetics when necessary. And when they do use prosthetics, they use devices called TORP and P or RP.
Total ossicular replacement prosthesis
Yeah.
and partial ossicular replacement prosthesis.
Right, and the choice depends entirely on exactly how much of the original bone chain was destroyed by the disease. Surgeons map this out using the Austin classification system, which grades the missing anatomy from type A to type D.
Okay, how does that grading work?
They look at 3 primary structural pillars: the intus, the malleus handle, and the state superstructure. If just one pillar is missing, you use a partial prosthetic. If all 3 are eaten away, you need a total replacement. It is literally identical to engineering a microscopic suspension bridge.
And once that bridge is built, you have to lay the roadway over it, the new eardrum graft.
Yes,
The surgeon has 2 choices for placing this new biological drum skin: underlay or overlay.
the great debate.
If they slide the graft underneath the remnants of the old eardrum, it has a much lower chance of lateralization, which is a complication where the eardrum heals too far outward, disconnecting from the bone bridge entirely.
But the underlay technique requires manipulating the tiny space of the middle ear, risking trauma to the delicate mucosal lining.
So what's the overlay then?
Conversely, the overlay technique involves placing the graft on the outside surface of the remaining drum. It perfectly preserves the delicate ecosystem of the middle ear cavity, but it requires stripping away the skin of the ear canal, and the healing process is notoriously long and agonizing for the patient.
Which leads us into the final and perhaps most stressful reality of this deep dive.
Complications.
The ecosystem of the rebuilt ear is profoundly fragile. The disease is gone, the microscopic titanium and cartilage pillars are perfectly balanced, the new eardrum is grafted, but things can fall apart incredibly fast post-operation.
They really can. A mastoidectomy and middle ear reconstruction carries severe complication risks. Aside from the facial nerve damage we mentioned earlier, patients can suffer sudden sensorineural hearing loss or dural injury where the fluid surrounding the brain begins leaking into the ear.
Yikes.
And a remarkably common complication occurring in 10 to 15% of these complex cases is extreme vertigo caused by a labyrinthine fistula.
What exactly is that?
This happens when the disease or the surgical drill creates a microscopic hole in the inner ear balance center. Inner ear fluid leaks out, and the patient experiences violent, incapacitating, room-spinning dizziness. Patients might even wake up and find food tastes like metallic cardboard, because the chorda tympani nerve, which governs a huge portion of your sense of taste, runs directly through the middle ear workspace.
Here's where it gets really interesting, though. The most fascinating complication takes us right back to our opening scenario.
The sneeze.
You survive the surgery, your face moves perfectly, your taste is intact. Then graft extrusion happens. The beautifully placed cartilage or titanium strut just pops out of place. Why does this happen?
Well, the protocols list several culprits, right? Inadequate patient preparation using a graft that is too flimsy, a dysfunctional eustachian tube, and of course, sneezing with an open mouth, or rather, failing to do so.
Right, sneezing with a closed mouth.
If we connect this to the bigger picture, to understand why a sneeze is so lethal to ear surgery, you have to look at the pneumatic physics of the human head.
Pneumatic physics, I love that.
It's basically plumbing. Your eustachian tube is the physiological pressure release valve that connects the back of your throat directly into your middle ear cavity. Its entire job is to equalize ambient pressure.
Okay.
When you sneeze, your lungs forcefully expel a massive volume of air. If your mouth is open, that aerodynamic pressure safely exits the body. But if you pinch your nose and close your mouth, that violent shock wave of pressure has absolutely nowhere to go.
It seeks the path of least resistance.
Precisely. The pressure wave gets forced violently up the eustachian tube and detonates inside the tiny middle ear space. It hits the underside of that freshly placed delicate eardrum graft and literally blows it off its microscopic pillars.
This is completely devastating. And how do doctors figure out that the mechanical bridge is broken without cutting the patient open again?
They rely on a combination of subjective and objective forensics. Subjectively, the patient will sit in the clinic and simply say, "Doctor, my hearing was great for a week, but now it's gone again." Objectively, the physician runs a series of acoustic physics tests. First, they strike a tuning fork and place it on the patient's skull. If the inner ear is healthy, but the mechanical bridge is broken, the tuning fork will reveal conductive deafness.
Meaning the vibration reaches the brain through the bone, but sound waves traveling through the air hit a dead end in the ear canal.
Exactly. Then they utilize tympanometry, which tests the acoustic flexibility of the eardrum.
How does that work?
Imagine bouncing sound waves off a snare drum. If the drum skin is tightly stretched over the instrument, the sound bounces back in a predictable curve. But if the tiny bones behind the eardrum are disconnected, the eardrum becomes completely floppy and disconnected from its anchor.
So it's too loose.
Yeah. The tympanometry machine pushes a puff of air into the canal, and because the eardrum is hypercompliant, the machine reads this as a massive, steep spike on the graph, known as a type AD waveform.
Finally, an audiometry test will confirm a worsened air bone gap, definitively proving that while the patient's neurological hearing is fine, they hear bone vibrations perfectly, the mechanical air-driven bridge is totally destroyed.
And when that happens, and surgical reconstruction fails entirely, or if the patient's anatomy simply won't support another operation, the clinical path pivots away from carpentry entirely.
Right, this is where advanced hearing aids enter the picture. For patients with a totally destroyed middle ear, or those suffering from canal atresia, where the ear canal itself is biologically fused jet surge, surgeons utilize a BAH.
A bone-anchored hearing aid.
Yeah, instead of trying to force sound through a broken middle ear, a small titanium implant is drilled directly into the skull bone behind the ear. A digital processor snaps onto it, captures environmental sound, and vibrates the skull directly.
It's so clever. The acoustic energy completely bypasses the ear canal and the middle ear bone, sending the vibrations straight into the inner ear cochlea.
It is a brilliant physiological workaround. You know, stepping back and looking at this entire landscape, the medical protocols we've decoded today really reframe how you think about your own body.
Absolutely.
We journeyed from a doctor diagnosing the exact location of a brain abscess simply by watching a patient try to touch a finger, to the drastic architectural choice of tearing down the bony walls of the skull to eradicate a bone-eating cyst.
And the micro-carpentry.
Oh yeah, we explored the painstakingly delicate microcarpentry of carving human cartilage to rebuild the acoustic machinery of hearing, all within a highly pressurized, fragile environment where a simple closed-mouth sneeze can blow the whole thing apart.
It's incredible.
It makes you realize that hearing isn't just biology, right? It is an impossibly intricate, analog mechanical system relying on microscopic moving parts and perfect pneumatic balances.
It absolutely is an analog system. And that leads us to the really compelling thought regarding the future of this medical field.
Oh, what's that?
Well, we've seen how deeply modern ear surgery relies on physical, manual carpentry scraping infected bone, harvesting cartilage, and balancing microscopic titanium struts. Given the massive risks of graft extrusion, recurrent infection, and sheer mechanical failure, you have to wonder if the future of audiology will eventually abandon these structural surgical repairs altogether.
That's a fascinating question.
Right. As biotechnology advances, might we one day rely entirely on targeted biological regeneration to regrow the ossicles? Or perhaps pivot exclusively to purely digital neural implants that bypass this fragile, complicated middle ear mechanics entirely?
That is definitely something for you to ponder the next time you listen to your favorite song. Or, naturally, the next time you feel a sneeze coming on.
Keep your mouth open.
Please, keep your mouth open. Thanks for joining us on this deep dive.